Welcome to Air Leak Management Part 2, focusing on ventilation strategies and clinical cases. We will cover evidence-based algorithms, drainage techniques, and ventilator optimization, as presented by Dr. Salem Keshba, neonatal specialist. This video will cover 6 sections: the pneumothorax management algorithm, mechanical ventilation strategies, drainage techniques, prognosis and complications, and 2 clinical cases. The cases focus on a preterm pneumothorax and a difficult air leak scenario. The pneumothorax management algorithm begins with a suspected pneumothorax diagnosis. If the patient is hemodynamically unstable, immediately treat for tension pneumothorax with needle thoracocentesis, followed by chest drain insertion. If stable, assess the size of the pneumothorax and manage conservatively if small and asymptomatic, or proceed to monitoring. Needle thoracocentesis is an emergency procedure for tension pneumothorax. Do not delay for a chest X-ray if the clinical diagnosis is clear. Key steps include proper positioning, sterile preparation, inserting the needle over the upper border of the rib, aspiration, and then securing the drain if needed, following up with the chest X-ray. This image illustrates the equipment used for emergency thoracentesis, including the angiocatheter, stopcock, and syringe. It also demonstrates the needle insertion technique and the subsequent air evacuation. This figure outlines the procedure for straight chest tube insertion. Key steps include patient positioning, incision between the fourth intercostal space and mid-axillary lines, puncturing the pleura, passing the tube, and securing the incision with a suture. This image details the percutaneous pigtail catheter placement using the modified Seldinger technique, involving the finder needle, guide wire, dilator, and eventual placement and attachment to a suction drainage device. Core mechanical ventilation goals in air leak syndromes aim for low PIP, with a tidal volume of 4 to 6 milliliters per kilogram. Permissive hypercapnia is used with short inspiratory times to reduce air trapping. Specific modes like SIMV with volume guarantee and HFOV offer distinct advantages and limitations in managing these syndromes. These chest X-rays illustrate localized and generalized pulmonary interstitial emphysema, or PIE. PIE is characterized by coarse, non-branching radiolucencies projecting toward the lung's periphery, which can be unilateral or bilateral. High-frequency oscillatory ventilation, or HFOV, is clinically effective for bilateral PIE and refractory air leaks due to its small tidal volumes and minimized alveolar pressure swings. Key strategies include starting MAP 1 to 2 cmH2O above the conventional MAP, optimizing for the lowest FiO2 for acceptable SpO2, and making PIE-specific adjustments like increasing frequency. Prognosis in air leak syndromes involves mortality and morbidity risks. Mortality for uncomplicated pneumothorax in term infants is low, but rises significantly in very low birth weight infants. And with tension pneumothorax or bilateral PIE, respiratory morbidity is increased, and neurodevelopmental deficits are a concern, particularly with concurrent IVH. Case 1 involves a 700 grams, 25-week infant with sudden deterioration on day 3 of life. The patient presented with bradycardia, low SpO2, high peak alarms, and unilateral bright transillumination, suggesting a tension pneumothorax. Immediate management for this tension pneumothorax involves prompt needle thoracocentesis without waiting for CXR, simultaneous oxygen administration, and calling for senior support. Diagnosis confirmation relies on transillumination and clinical signs. Ventilator changes include reducing PIP and maintaining volume guarantee. A formal chest drain is needed if the PTX recurs or the air leak persists. The time course for Case 1 demonstrates the rapid response required for tension pneumothorax. Needle decompression at T equals 5 minutes led to stabilization, followed by a chest drain insertion. Resolution occurred by 48 hours. Key learning points emphasize clinical diagnosis over imaging, the temporary nature of needle decompression, and the importance of volume-targeted ventilation. Case 2 involves a 600 grams, 24-week infant who developed bilateral PIE on day 2. A right-sided pneumothorax developed on day 3, treated with needle decompression and a chest drain, followed by a switch to HFOV. On day 5, the infant acutely deteriorated with severe bradycardia and a quote halo of air on CXR, highly suspicious for pneumopericardium. Case 2 presents a code situation, cardiac tamponade from pneumopericardium. The emergency response requires recognizing and declaring the emergency and immediate pericardiocentesis. This is followed by simultaneous resuscitation and, if necessary, pericardial drain placement. Further steps include revising the ventilator strategy, minimizing pressures, reducing MAP, and allowing permissive hypercapnia. Early honest communication regarding prognosis and a goals of care discussion with the family are also critical steps in this complex scenario. Key learning points from Case 2 highlight that pneumopericardium is the rarest and most lethal air leak. PIE is a red flag for escalating air leaks, requiring a switch to HFOV with incremental MAP reduction. Additionally, high HFOV MAP worsens air leaks and must be carefully titrated. Prognosis communication is essential, and prevention is always better than treatment. Let's test your knowledge with a board-style multiple-choice question. The scenario describes a 600 grams infant with a, quote, halo of air and sudden cardiovascular collapse. The most appropriate immediate action is pericardiocentesis via a subgyphoid approach. A clinical pearl is that the CXR halo plus hemodynamic collapse mandates immediate pericardiocentesis without waiting for further imaging.